Common questions about chronic hepatitis B infection. What are the symptoms of chronic hepatitis B infection? In most cases, chronic hepatitis B infection has no specific symptoms, but leads to the development of liver disease such as cirrhosis and liver cancer in around 15 to 25% of cases if not adequately managed. The generally long lead time before these outcomes reinforces the need for timely diagnosis and intervention. What is the natural history of chronic hepatitis B virus infection? The natural history of chronic hepatitis B virus infection depends on complex interactions between host, virus and environment. There are 4 phases of chronic hepatitis B, and the host immune response in each phase determines the outcome of infection and the severity of liver injury. Liver damage is caused by the host immune response rather than the virus itself. Phase 1, Immune tolerance phase. This stage is characterized by hepatitis B e antigen positivity, high HBV DNA levels of more than 20,000 IU per milliliter, normal ALT levels and minimal level liver injury. During this phase, which may persist for decades, liver inflammation or fibrosis is either absent or minimal. This phase is associated with a low risk of progression to advanced liver disease, and it is thought to occur most commonly in those who acquire the infection vertically from HBe antigen-positive mothers. Patients are highly contagious in this phase. Phase 2, Immune clearance phase. This stage is characterized by HBe antigen positivity, and fluctuating levels of HBV DNA and ALT. The host's immune system recognizes the HBV as foreign, and mounts a cytotoxic response to infected hepatocytes. Recurrent bouts of active inflammation and, eventually, fibrosis can occur in the liver following these repeated immune-mediated attacks. An important outcome of this phase is the seroconversion of HBe antigen to HBe antibody, which is associated with a lower level of viremia. The observed rate of clearance of HBe antigen in those with average is 8 to 12% per year. Phase 3, Immune control. In this phase, liver inflammation is minimal, HBV DNA is undetectable or low level at less than 2000 IU per milliliter, anti-HBe is detected in the serum, and liver function tests are usually normal. These patients are at low risk of developing advanced liver disease and its related complications. Phase 4, Immune escape. This phase is characterized by negative HBe antigen, positive anti-HBe and persistently detectable viral load HBV DNA more than 2000 IU per milliliter with fluctuating or elevated ALT levels. It occurs due to the selection of a mutant HBV that does not produce HBe antigen but is still able to replicate. This immune selection process is likely to occur late in the natural history of chronic hepatitis B. These patients tend to be older and have more advanced liver disease. The natural course of patients within the immune escape phase is characterized by fluctuations in clinical status, and in biochemical and viral load parameters, caused by recurrent hepatic flares. Although patients in the immune escape phase tend to have lower HBV viral load than those in the immune clearance phase, they display more hepatic inflammation on liver biopsy. Consequently, the annual incidence of cirrhosis is significantly higher. Who should be tested for hepatitis B? The following groups of people should be screened prior to hepatitis B vaccination. Persons born in intermediate and high endemic areas. Young adults. Healthcare workers. Pregnant women. Contacts of subjects with chronic hepatitis B virus infection. Persons with multiple sexual partners / or history of sexually transmitted diseases. Individuals with chronically elevated alanine aminotransferase or aspartate aminotransferase. Individuals infected with hepatitis C virus or human immunodeficiency virus. Men who have sex with men. Subjects with high-risk behaviors. Immunocompromised subjects. Immigrants. Prisoners. All of the at-risk groups outlined above should be opportunistically screened for hepatitis B virus if their status is unknown, by ordering all 3 of the following serological tests: HBs antigen, anti-HBc, anti-HBs. How should patients with chronic hepatitis B be managed? Check for other infections. Infection with hepatitis C can cause a life-threatening flare of liver disease in people with chronic hepatitis B, so it is important to test for immunity and offer vaccination if susceptible. Hepatitis C, hepatitis D and HIV can all complicate the assessment, monitoring, management and treatment of people living with HBV. All patients diagnosed with chronic hepatitis B should be screened for these infections, and referral to a specialist should be considered in the setting of co-infection. Identify, screen and vaccinate contacts. Hepatitis B is a vaccine-preventable disease. Family members and household contacts, as well as sexual partners, should be screened and vaccinated if they are susceptible. Establish the phase of chronic hepatitis B. An essential part of the post-diagnosis workup of a patient with chronic hepatitis B is determining the phase of infection. The phase of infection is largely determined using HBV DNA levels, alanine aminotransferase and HBe antigen or anti-HBe status. The phase of infection indicates the likelihood of progressive liver damage, and is used to help decide which patients need further investigation, for example liver biopsy, and for consideration of antiviral treatment. Arrange regular monitoring. All people diagnosed with chronic hepatitis B require regular monitoring. The frequency of this monitoring varies according to the phase of infection, the extent of liver damage present, whether the person is receiving treatment, and the presence of other complicating factors such as co-infections, immunosuppression and other causes of liver disease. However, the minimum recommended interval for this monitoring is yearly, including clinical review, liver function tests and HBV DNA viral load. Other tests can be indicated, including HBe antigen or anti-HBe status in phases 1 and 2, and hepatocellular carcinoma surveillance in eligible patients. Hepatocellular carcinoma surveillance. Chronic hepatitis B is a leading cause of hepatocellular carcinoma or HCC. People who develop primary liver cancer are generally diagnosed late and have poor survival. Those whose liver cancer is detected through screening have significantly improved survival, and that in combination with appropriate treatment for chronic hepatitis B, HCC surveillance is cost-effective as a cancer prevention intervention. For these reasons, HCC surveillance with liver ultrasound is recommended for patients at increased risk. This surveillance should be performed every 6 months. Who should be referred for treatment? Determining a patient's phase of chronic hepatitis B infection is crucial to determining the need for treatment. In general, those with active viral replication, as indicated by elevated HBV viral load, and active liver damage, as indicated by elevated ALT or inflammation on biopsy, or evidence of fibrosis on biopsy or non-invasive testing, for example FibroScan, should be considered for treatment. Any patient with active liver disease or suspected cirrhosis should be referred for specialist assessment and consideration of therapy. Seeking expert advice is also recommended when chronic hepatitis B is complicated by other factors. For example, pregnant women may require therapy to prevent vertical transmissio. And those co-infected with HIV, HCV or HDV require special treatment approaches. Patients undergoing immunosuppressive therapy should be referred for consideration of preemptive treatment to avert a flare of chronic hepatitis B during therapy. How successful is treatment? The short-term goals of therapy are suppressing HBV viral load and reducing liver inflammation as reflected by the ALT level, and these are the key indicators used to monitor response. For most patients, antiviral therapy for HBV is effective at reducing the risk of progressive liver damage, cirrhosis and liver cancer. Recent evidence suggests that just 4 years of treatment reduces the risk of cancer by more than half, and reversal of cirrhosis is increasingly recognized. The first-line oral antiviral therapies, for example entecavir and tenofovir, are potent, are well tolerated, and demonstrate very low incidence of resistance.
Audio Jungle. Audio Jungle.